The Vein Consult program has shown that chronic venous disease affects the venous system of the lower limbs of 8 out of 10 people. Today, we understand the disease and its mechanisms better, which allows us to treat the patient better. Venous pain is the most common complaint leading to the diagnosis of chronic venous disease, and it has a significant effect on quality of life. It can be present whatever the stage of chronic venous disease and can occur in the absence of any abnormality seen on clinical examination. Chronic venous hypertension is the underlying cause of all forms of chronic venous disease and the trigger for the mechanisms that produce the inflammatory cascade leading to the signs and symptoms of chronic venous disease. When venous hypertension is chronic, the associated altered blood flow leaks through the valves, and flow reversal triggers the activation of endothelial cells and leukocytes. These cells release inflammatory molecules, including adhesion molecules, thereby leading to the adhesion and migration of leukocytes through the endothelium of the venous valves and vein wall. The resulting production of toxic metabolites and free oxygen radicals leads to vein wall weakening and valve damage, which will eventually cause valve failure. Incompetent valves allow venous reflux to occur, thereby reinforcing venous hypertension and allowing the disease to progress. Its repercussion on valves and the microcirculation leads to other similar inflammatory events also involved in the progression of chronic venous disease. The activated leukocytes are associated with an increase in capillary permeability and fragility, which can lead to edema and tissue injury, and eventually skin changes and ulcer formation. Inflammatory mediators also act as a chemical signal, stimulating C nociceptor fibers, and this causes the painful symptoms of chronic venous disease that patients express as venous pain. Thus, leukocyte-endothelium interactions are at the core of the tissue injury associated with all stages of the disease. That's why treating chronic venous disease means targeting venous pain and therefore inflammation. It has to be the main objective when you decide to prescribe a drug. Through its noradrenergic action on the venous wall, Daflon 500 mg increases venous tone within the first hour, reduces venous stasis, improves lymphatic drainage, and protects both the macro and micro circulation. A growing area of evidence shows that the underlying protective effect of Daflon 500 mg is also a result of its action on leukocyte-endothelial interactions. Indeed, Daflon 500 mg can reduce leukocyte activation in the veins of patients. Findings suggest that by inhibiting the inflammatory reaction triggered by venous hypertension, Daflon 500 mg may delay the development of reflux and suppress damage to the venous valves and the vein wall. Each fraction of Daflon 500 mg's unique composition contributes to its unsurpassed clinical efficacy, since each of the flavonoid fractions present in Daflon 500 mg decreases the appearance of leaky sites. Thanks to a high-quality process, Daflon 500 mg particles are guaranteed to contain a minimum concentration of each concomitant active flavonoid fraction. Thanks to a high-quality micronization process, Daflon 500 mg particles measure less than 2 micrometers. The result is a significant increase in the drug's gastrointestinal absorption, and the synergistic efficacy of each of its components. This greater absorption provides a pharmacokinetic explanation for its enhanced and rapid clinical efficacy on venous tone, pain, and edema. Daflon 500 mg is unique, being the only vein-specific analgesic drug with a high-quality micronized formulation. Hence, Daflon 500 mg is the only venoactive drug with a first and unique position in the latest international guidelines.